Welcome to First Do No Harm with Massachusetts Citizens for Life board member and physician Dr. Mark Rollo. This broadcast will focus on medical ethics from a Catholic perspective and address abortion, physician-assisted suicide, contraception, natural family planning, IVF, healthcare proxy, and other topics. Please be advised that this show may not be appropriate for children under 13.
Hello and welcome back to First Do No Harm, a show about medical ethics from a Catholic perspective. I'm Dr. Mark Rollo. For the last 2 weeks, you have heard the first two parts of my interview with Dr. Kris Correira, pro-life Catholic clinician in emergency and family medicine. We have discussed the roots of physician-assisted suicide. She explained some of the modern-day roots, which include the evil of eugenics. This corrupt ideology also undergirds the anti-life mentality of abortion and contraception. All three entities, contraception, abortion, and assisted suicide, are fruits of the same poisonous tree. All are part of the culture of death. All are directed at eliminating inconvenient, unwanted life. You have also heard us discuss how the corrupt ideology of eugenics led to forced sterilization in the United States by way of a Supreme Court decision from 1927, Buck v. Bell, which ordered the forced sterilization of Carrie Buck, the so-called feeble-minded daughter of a feeble-minded mother, and herself the mother of a feeble-minded child. This decision established the legal authority for sterilizing more than 60,000 U.S. citizens in more than 30 states before it finally ended in the 1970s, largely due to the opposition from the Catholic Church. For many, the profession of medicine, fostered by Hippocrates and his followers, has morphed into not the profession of medicine, but the business of medicine, which seeks to save money by not saving people. Eliminating people is even more cost-effective. This is facilitated by the end-of-life documents of advance directives and MOLST, medical orders for life-sustaining treatment, which, while they do have their place in patient care, are often misused to shorten life and so save money. Such decisions are often cloaked in the notion of autonomy, which rationalizes that we are just respecting the patient's wishes. Today, in part 3 of my conversation with Dr. Kris Correira, we will further our discussion regarding MOLST and how its use in cyberspace will put even more people at risk. Let us first, as always, begin with prayer. For as stated by the U.S. Catholic bishops, only with prayer that storms the heavens for justice and mercy, prayer that cleanses our hearts and souls, will the culture of death that surrounds us today be replaced with a culture of life. O God, help us to value life in all of its stages. Help our culture understand the self-evident truth that all life is of intrinsic and infinite value. And we ask this in Jesus' name. Amen. And now, part 3 of my interview with Dr. Kris Correira. But ultimately, as we were saying, that there is a big push for this because it's a way to save money. And assisted suicide, in many respects, is a way of saving the health system money. And MOLST is kind of a vehicle for that. So what do you see as the dangers of the advance directive, and then what are the dangers of MOLST, because they are two separate things?
Right, right. So, as I say, the advanced directives are not enough, but of course they've come up with a number of methods for having these conversations, whether it's the 4 wishes or the conversation project or whatever you want to call them. It's people to have these discussions. But you and I know the medical system is its own little world, right? And patients don't really understand how some of the things they say or do translate into the medical world. In fact, there's a great group of studies done by Fred Marachi called Triage. It's the realistic interpretation of advanced directives. And he has shown every group, physicians, EMTs, residents, even nurses, that every one of them screw up when they come to trying to interpret an advanced directive.
Yeah, so how do we expect patients to understand? And
that's right. And he did a really good study where he went into a hospital system, found out who had DNR, these MOLST form, do not resuscitate orders on them. And then he compared them with a frailty scale and with what the patient thought. And there was a huge amount of discordance. There were a lot of people there who didn't know they had these TNR orders put on them. They did not know. And they did not score high on the frailty scale. In other words, they were not particularly frail or end of life or terminal, but they had MOLST forms on them. They had do not resuscitate forms put on them. I mean, that's what happens with these papers, because now they're medical orders. A patient and a doctor has to sign it.
Well, I find it disturbing. Just the advanced directives themselves are disturbing, because you're asking people usually way ahead of time to determine what kind of care they want, what kind of care they don't want, when often they have no idea, because they have no idea what kind of an illness they might have in the future. And and MOLST is worse in some ways, because you're checking boxes on a form which says, do you want to be resuscitated? Do you want to be intubated? Do you want dialysis? Do you want a feeding tube? When in most cases, you have no idea what you're going to want, in the moment of need. So they're both very dangerous, particularly the MOLST, because, there is a use for them when you really are in the moment of need. But if you're not in the moment of need, I like what you told me about the chaplain at St. Vincent Hospital and how he referred to MOLST forms. Do you remember what you told me there?
He often has these great expressions.
Yeah.
He says, don't give them the bullets to shoot you with.
Exactly.
Because they will.
Right. So don't sign those forms unless you're really, in the moment of need, and you are literally in the last moments of your illness and the last days or weeks or months of your life.
Absolutely. There is a place for MOLST, as you said, but if you're having these conversations properly, like I recently had a conversation with a family that, I knew the family, but I didn't know the circumstances of the loved one that they were talking about hospice for. Very devout Catholic family. And I'm talking with them, and I'm listening to what his wife is saying and what she's saying. And I spent a good 45 minutes or more. This was on the phone before I even went up to sit with the family. And I said, given what you're saying, it really sounds like you're ready for this MOLST form, because he was really at the end, and they really did not want interventions. Like, it didn't matter what those interventions might have done on the other side, because that's where he was in his disease state, and it was a perfectly reasonable, very within the teachings of the Catholic Church. Right. The problem is the MOLST is pushed off as, you want to have control of your care, sign this MOLST. Well, no, that MOLST actually doesn't really give you control of your care. In fact, there's good studies out there that show, if you ask people, who do you want making your medical decisions? If you can't, if somebody you choose, or the doctor, or both. They'll say, somebody I choose, like your surrogate, your healthcare proxy. That MOLST form will go do an end run around your surrogate. So you actually are not getting, if your wishes are to have your surrogate decide in the moment, what should be done, those MOLST forms are actually taking that control.
Yeah, well, actually, just to amplify that point, I remember when I was talking to Pat Stewart, who was the executive director of Mass Citizens for Life. She talked about how these documents, these MOLST forms, have led EMTs, first responders, to get on the scene and not give care because they had a do not resuscitate form. Well, do not resuscitate should mean if the person's in cardiac arrest, don't do CPR. But oftentimes, when they see these MOLST forms, and a person is not in cardiac arrest, they're simply deteriorating. They might be in heart failure. They might be short of breath. Oftentimes, they'll see these forms and they won't give care. So, we're talking about DNR, not do not treat. But often these MOLST forms are interpreted as do not treat.
That's exactly what these studies were showing. I'll tell you from my personal experience, taking care of my stepfather, he had renal cancer that went to his lungs, a little bit to his brain. He also had heart failure. He also had renal failure. At the dialysis, they had him sign a MOLST form at the dialysis. I mean, not unreasonable, but he had already been to the ER once because he went into paroxysmal AFib. So suddenly his heart went out of beat. And he knew it. Everybody knew it. He became diaphoretic. He became nauseous. He became very uncomfortable. And, of course, the poor cardiologist was like, they tried using a medicine to break the heart rate so it would go back normal. And the cardiologist was very concerned. Oh, my gosh, he's got brain mets. I don't want to, because the next step is to do what's called a defibrillation, which is with, it's called a cardioversion with electricity to the chest. And he's like, he's hearing his history, and he's like, oh, my gosh. And he wanted to make sure that this truly was a new onset. It's a whole medical thing. But anyway, the point is, they debated it. The medicine ended up working, and his heart went back into rhythm. And instantly, he became better. He felt better. A few weeks later, he needed to go back to the ER because he was not doing well. And they called the dialysis center, and they told him he had this MOLST form, this do not resuscitate. And I looked right at the ER doctor, and I said, he has a history of paroxysmal AFib. If he goes into AFib and you can't break it with medicines, you will defibrillate. You'll cardiovert him, right?
Yeah.
And he said, no, that's a resuscitation.
Yeah,
no,
right.
It's not.
Right.
No,
right.
It's not.
Yeah, so it can be a very dangerous thing.
That's right. So,
incidentally,
reason.
One thing that came to mind is we both said that there is a place for MOLST, but it has to be done carefully. Also, for our listeners, there is a better MOLST form, or POLST is another term for physician orders for life-sustaining care. That's on the National Catholic Bioethics Center website, ncbcenter.org. And because the current MOLST forms that are out there are very biased toward not treating. And you want a form that's balanced and that will not be misinterpreted like what happened with your relative or where there was a bias toward not treating rather than something that's truly neutral and specified what you will do and what you won't do. So that's important for people to
just be clear that there is one on the National Catholic Bioethics Center site, which I have. You need to purchase it, and it's not intended for people to just download, because remember, these are these are meant to be done in the situation of discussion with your healthcare professional.
Right.
So I have it so that when I discuss it with people and they want that form, we'll go through the form.
Yes.
But it's not meant for sort of the general, and it says that when you look at the page.
Exactly.
You're
right. They do make that point. You don't just download it and sign the form and you're all set. It's just an example of something that you might want to discuss at some point with your healthcare provider when it's needed. But I wanted to finally, we don't have too much time left, but I did want you to talk about the latest iteration of the MOLST forms, which is the eMOLST. Can you talk a little bit about that and why that is fraught with even more danger?
Yeah, one of the things I used to always say is, at least in Massachusetts, we don't have an electronic registry with the MOLST.
Mm-hmm.
Well, now we do.
Mm-hmm.
Now we do.
Mm-hmm.
It can be signed online, so you or your surrogates can, surrogate if you are unable, can sign it, and your clinician, so it's physician, nurse practitioners, or physician assistants can sign these forms, because we're the three that are clinically able to have these discussions and understand the medical implications of them. Though I'll tell you, I know for a fact that a lot of times they're sending social workers in to do it. And that's not appropriate because they don't have the medical knowledge in terms of especially prognosis.
That's right.
And all of that. It's just not appropriate.
But like you said, they do have it in there that if you want to sign on to this registry, you as the physician or physician assistant or nurse practitioner can authorize other people like case managers and nurses to start the conversation. Like you said, many of them don't have the medical background, and so they may not be informed appropriately. And unless there's really diligent oversight by the medical person, some of these conversations can begin inappropriately.
And this is what the biggest problem with MOLST, and probably everywhere else too. One is the fact that patients don't understand what the implications of these forms are, what it means. The first thing a patient will say to me when I'm having an advanced directive discussion is usually, I don't want to be stuck on a machine.
Yeah.
All right, that's fine. Who does?
Right.
But what they're saying in the MOLST to clinicians who are having this conversation, if somebody says that, you're to translate that immediately into a do not resuscitate, do not intubate. When I take the time to ask the patient, all right, well, what if it's something, what if you were in the hospital and then suddenly you went into cardiac arrest, or what if it's something where you might recover, we don't know, you're not in cardiac arrest, but maybe they want to put it, something.
Yeah, pneumonia or something.
Most of them will be like, I'd like you to at least do a trial, right? There's a trial of treatment, and then you can withdraw the treatment if it doesn't seem to be helping. That gets lost in that translation. So that, and in eMOLST, it's very... that whole translation process, if they say this, so you're just asking them in general. So how do you feel about being resuscitated? How do you feel about being hooked to a machine? How do you feel about somebody doing CPR on and breaking all your ribs? I love the way they have these conversations, right? Is that how we have surgical, I'm going to have surgery, I'm going to go take a saw, I'm going to cut your sternum open, I'm going to rip it open, and then I'm going to go in and do your heart or whatever.
How would you like someone pounding on your chest and breaking all your ribs?
Right. Do you want that? No? Okay. Well, I mean, that's how these conversations are happening, or they're not happening. Like the patient that I got sent home from a rehab, we get called from the nurse saying, she's got a DNR order, she's got a MOLST signed, and she didn't know she signed it, and she wants to be resuscitated. Once that goes into a registry now, that's a whole nother step to try and get that done.
And I love the way that I was reading something on the Blue Cross Blue Shield website, because they're part of the Mass Coalition for Serious Illness Care. And I was reading through it, and the one thing struck me. It said in this document, this electronic registry, a trusted single source of truth. Don't you love that? A trusted single source of truth. What a great thing to have. But basically, the decision-making on your life is kind of out there in the ether, on the internet, for anybody to look up and possibly misinterpret what you actually want. So, again, it gets back to the idea of not giving people the bullets to kill you. That's
right. And in this age of undertreatment in medicine, you're much more likely to get undertreated than overtreated.
Yep. Undertreatment.
People say the MOLST is for control. What I say, and the way it should be viewed, is the MOLST should be signed if you're in a place like a dialysis unit, like an intensive care unit, where something might happen suddenly, and your surrogate is not there.
Right. And that's and that's the take-home message, because this can get complicated, but the take-home message is you don't sign things like MOLST forms unless you're in the moment of need, and like you said, if something if you're in an ICU or you're trending toward that, you're sick enough that you may end up there, that's when you want to consider things like that.
Right.
So
the whole idea of you don't want to die at home, we need this because you want to make sure you arrange it so you die at home.
Yeah.
I mean, dying at home is nice, but I don't want to give up some kind of treatment that might extend my life a little bit to die at home.
Right. You have your own website, right, called natureanddignity.com, is that right?
That's right, natureanddignity.com, and I'm building it little by little.
Mm-hmm.
And I try to send out more newsletters and get the resources on there for your presentation, the presentation that you give on the abandonment of Hippocratic medicine.
Mm-hmm.
And I have a presentation on end-of-life discussions, to introduce people to a lot of stuff we were talking about in terms of healthcare proxy, advanced directives, and MOLST. And then, of course, the resources about assisted suicide. Right now we're looking to the fall of this year for a hearing. Massachusetts is the only state that has active legislation right now. So the guns are aimed at us.
Right. So it's critical. I'm glad you brought that up because I just want to remind people, as I've done in previous shows, now is the time to contact your state senator, your state representative, and tell them that you want your doctor to be a healer and not a killer. And it's time to tell them that we don't want physician-assisted suicide in Massachusetts. Thank you very much, Kris, for this is very enlightening, especially the historical aspect of all this. And before we say goodbye, are there any last words of wisdom you may have for us?
We need to stay connected to God, and particularly the moral law that flows from God. I mean, Veritatis Splendor was written to address some of this relativism that had crept into moral theology as well.
Right.
Never mind the society around us. JP2 exhorted us to teach not just the faith, but the morals, and in the new evangelization. We've done well with the faith. We need to be stronger on the morals. And assisted suicide is part of that. And so First Fridays, First Saturdays, praying for reparation, that there can be a renewal in this area, in our culture, and in our church.
Well, very good. And so, Dr. Kris Correira, thank you very much for joining us today.
Thank you, Mark. It's been wonderful talking with another healthcare clinician that understands these things so well.
Thank you very much. This concludes my interview with Dr. Kris Correira. Until next time, remember, we should always treat life with care and respect. And at the very least, we should first do no harm.
First Do No Harm with Dr. Mark Rollo is produced at WQPH 89.3 FM Shirley, Fitchburg. We are very happy to share it with other networks.
This is Dr. Mark Rollo, Massachusetts physician, and these are reasons to reject physician-assisted suicide. Reason number 3. Assisted suicide is a recipe for elder abuse. It is estimated that 10% of elders in Massachusetts are subject to abuse. Here are the statements that I often heard from my elderly patients. Doc, I feel like giving up. I'm tired of living. Doc, don't get old. I don't want to be a burden. Depending on the mindset of the physician and the legal environment, these statements can be taken down 2 very different pathways. One of hope and encouragement, or one of despair and death. The story of Kate Cheney is a case in point. She was one of the first victims of the assisted suicide law, which went into effect in Oregon in 1997. This mildly demented elderly woman with terminal cancer was taken doctor shopping by her daughter, who was seeking assisted suicide for her. 2 physicians refused, citing Kate's inability to comprehend the situation. Ultimately, a so-called ethicist from Kate's insurance provider declared her competent, and shortly thereafter, Kate was dead from a prescribed lethal drug. How many Kate Cheneys are there in Massachusetts who will be abused by potential heirs who can witness the so-called request for suicide pills, or who will be steered toward suicide by profit-driven insurance companies? The 2021 assisted suicide bill before the Massachusetts legislature is euphemistically called an act relative to end-of-life options. Call your state representative and state senator today at 617-722-2000 or go to malegislature.gov. Tell them we already have end-of-life options. They are called hospice and palliative care. Tell them you want your doctor to continue to be a healer and comforter, not a killer. Please continue to listen for more reasons why assisted suicide is dangerous for individuals and disastrous for society.
Thank you for tuning in to First Do No Harm. Dr. Rollo welcomes your questions and comments. You may contact him at markrollo978@gmail.com. That's MARKROLLO978@gmail.com. Thank you, and until next week, remember, first, do no harm.